Imagine a door in your house. Right. But it's a door that swings open and slams shut like 100,000 times a day.
Every single day.
Yeah.
For, 80 years.
Exactly. Every single day.
Yeah.
And I mean, you have to wonder what happens to the hinges? What happens to the frame? Because usually when we talk about the human heart, we treat it like this, I don't know, this mystical emotional center.
Right, or like this hyper-complex electrical grid that cardiologists are just constantly monitoring on screens.
Yeah, exactly. But today we are taking a journey into the literal plumbing of your own body. Because at its absolute core, the heart is basically just a mechanical pump system.
2 pumps, 4 doors.
2 pumps, 4 doors. And when those doors stop working right, when the hinges get rusty or they just don't shut all the way, the entire system backs up.
It's the absolute definition of a mechanical failure. I mean, we romanticize the heart, sure, but ultimately it obeys the laws of fluid dynamics.
It really does. And welcome to the deep dive. Today, we're looking at a huge stack of medical history, clinical studies, pathophysiology notes, all zeroing in on valvular heart disease, or VHD.
Yeah.
And our mission today is really to demystify this plumbing, to explore how these diseased valves disrupt our blood flow and to uncover how the medical world's understanding of this condition has completely flipped over the last century.
It's been a massive shift.
Right. So, okay, let's unpack this. Think of this as a shortcut for you to become highly informed on a topic that honestly affects aging populations everywhere. I mean, we're all getting older, our bodies are all experiencing wear and tear. So understanding how this works is basically looking into the future of our own health.
Absolutely. And to understand how this disease and, well, how our view of it has changed, we first really need to look at the fundamental mechanics of how a heart valve actually breaks.
Right, the anatomy.
Yeah, the anatomy lays the groundwork here. So the heart operates as 2 pumps working in a series. On the right side, you have a pump pushing deoxygenated blood over to the lungs.
Okay.
And then on the left side, you have a much stronger pump pushing that fresh oxygenated blood out to the rest of the body.
Right. And between these chambers and at the exits, you have the 4 doors. You've got the tricuspid and pulmonic valves on the right and the mitral and aortic valves on the left. But the thing that, honestly blew my mind a bit is that these valves have no muscle of their own.
No, not at all.
They're completely passive. They are literally just one-way check valves that swing open and slam shut purely based on the pressure building up on either side of them.
It's an incredibly elegant design.
Yeah.
Until the mechanics fail. And the material we're looking at highlights 2 fundamental failure modes.
Yeah, and so to really visualize this, let's think about water moving through a pipe.
Okay, good analogy.
So the first failure mode is called stenosis. Basically, the valve won't open properly, it's obstructed, it's stiff, and it's exactly like taking a garden hose and just squeezing it really tight.
Well, you're restricting the flow.
Exactly. And the pressure behind your hand just shoots way up.
Because stenosis is, at its core, a pressure problem. The pump has to work so much harder to push the same amount of fluid through this tiny, narrowed opening.
And then the second mode is regurgitation, where the valve fails to close fully, so blood literally leaks backward. And, people always say it's like a leaky bucket, but that never quite made sense to me.
Oh, yeah. It's not a great visual.
Right. I prefer to picture it like a sump pump trying to clear a flooded basement, but the one-way check valve in the pipe is totally broken.
That was much better, yeah.
So the pump pushes a gallon of water up the pipe, but the second it stops, half a gallon rushes right back down into the basement.
So it's constantly repumping the same water.
Exactly. It has to work twice as hard just to make any progress.
Right. And so regurgitation is fundamentally a volume problem.
Yeah.
And understanding that difference, pressure versus volume is crucial because of how the heart responds.
Right, the remodeling.
Yes. The heart muscle itself actually changes shape to compensate for these broken doors. It undergoes what we call cardiac remodeling.
Okay, let me see if I can, deduce how this works mechanically. So if we look at the squeezed hose scenario, the stenosis, the chamber upstream of that narrative valve is pushing against immense resistance, right? So it's basically weightlifting. And when a muscle lifts heavy weights, it bulks up, it gets thicker.
You are describing concentric hypertrophy perfectly.
No.
And, the clinical numbers here are just striking. So a normal aortic valve has an opening of about 3 to 4 square centimeters.
Okay.
But in severe aortic stenosis, that opening shrinks down to under 1 square centimeter.
Oh, wow. That's tiny.
It's a pinhole. And normally the left ventricle generates a pressure of about say 120 millimeters of mercury to push blood to the body. With that tiny opening, it might have to generate 200 or more just to force the blood past the obstruction.
Just to get the normal amount of blood out.
Exactly. And to generate that kind of force, the heart wall gets really thick. But because the heart is an enclosed sphere, it actually sickens inward.
Wait, so it shrinks the actual chamber size?
Yes. It works for a while, it compensates,
Yeah.
but eventually that thick muscle becomes super stiff. It's like a bodybuilder who's so bulky they can't even touch their toes, It impairs its own ability to relax and fill properly.
Okay, so stenosis gives you a thick, stiff heart. So then, if a squeezed hose makes the heart thick and stiff, I imagine the broken sump pump, the regurgitation, does something completely different, right?
Very different.
Because the heart is basically drowning in this extra fluid that keeps leaking backward. It must have to, stretch out just to hold all that sheer volume.
Exactly. That is eccentric hypertrophy. Because regurgitation raises the effective preload, which is just the amount of blood the heart has to deal with before it even squeezes. The chamber has to pump its normal amount of blood, plus all the extra blood that just fell back in.
Right.
So to handle this massive volume, the heart dilates. It stretches out like an overinflated balloon.
Yeah.
And over time, it just loses its elastic snap.
That is wild. The exact same valve can cause the heart to either get super thick and stiff or huge and stretched out, just depending on whether it's a tight door or a leaky door.
Yeah.
But wait, can you have a squeezed hose and a broken sump pump at the exact same time? Can a valve be both narrowed and leaky?
Oh, absolutely. Mixed disease is incredibly common, despite this weird misconception that these are mutually exclusive opposites.
Oh, really?
Yeah. Think about a heavily calcified, rigid valve. It might not open all the way, right?
Yeah.
So that causes stenosis. But because it is so rigid, it also can't snap shut all the way, which causes regurgitation.
Oh, man. So you got the pressure problem and the volume problem simultaneously.
It's a total nightmare for the heart muscle.
I can imagine. Now, obviously, we know all this today because we can look inside the chest with incredible imaging. But the physical changes we just talked about, the inward thickening, the ballooning dilation, that's all happening entirely out of sight.
Right in the dark.
So how did doctors, 100 or 200 years ago even know this was happening?
Well, nobody invented valvular heart disease, obviously. It's basic human anatomy. They simply invented ways to observe it. And the breakthrough started with, of all things, a rolled-up piece of paper.
Yes, the invention of the stethoscope. So in 1816, there's this French physician named René Laennec,
Right.
and he rolled a sheet of paper into a cylinder. The story goes that he didn't want to, awkwardly press his ear directly against a young female patient's chest, because that was the standard practice of direct auscultation back then.
Modesty drove the invention, but the physics of sound drove the revolution.
Exactly. By using this paper tube, he realized the sounds of the internal plumbing were actually amplified, and so he laid the groundwork for matching specific whooshing murmurs to specific broken valves.
Suddenly, doctors were listening before they could ever see.
Right, which kicked off this incredible 19th century eponym explosion. It just seems like this wildly competitive era where literally every physician wanted a physical sign named after them.
Oh, they absolutely did. And they were diagnosing severe valve disease with nothing but their eyes, their fingers, and just a really acute understanding of fluid dynamics.
The one that really stands out to me is Dominic John Corrigan in 1832. He described the water hammer pulse. It's this collapsing arterial pressure wave that you could feel in a patient's wrist. And if you think about the physics of severe aortic regurgitation, it makes perfect sense.
Yeah.
The heart gives this massive, powerful squeeze to clear all that extra volume, right? Which creates a huge surge of blood forward. But because the valve doesn't close, a massive amount of that blood immediately falls completely backward into the heart.
So the physician feels a sharp, bounding pulse on the wrist that just instantly vanishes into a vacuum.
It's brilliant. But the one that really got me was de Musset's sign.
Oh, that's a fascinating one.
Named after this 19th century French poet, Alfred de Musset, who, by the way, had syphilis, which can actually destroy the aortic valve.
It can, yeah.
And his regurgitation was so severe, so much blood was sloshing forward and backward in his body that his entire head bobbed rhythmically with every single heartbeat.
Just unbelievable.
Doctors were literally diagnosing heart failure by watching a guy's head nod from across the room.
It's wild. But, while these historical signs are incredible feats of clinical observation, they did create a misconception that lingers pretty heavily today.
What's that?
Well, people often think I have a heart murmur, therefore I have a diseased valve. But a murmur is just a clue. It is absolutely not a diagnosis.
Oh, I see.
Yeah, most murmurs, especially in kids or young athletes, are what we call innocent or functional murmurs. It's really just the sound of normal, healthy blood flowing turbulently through a completely healthy pipe. You cannot know the true structural integrity of the valve just by listening.
Right. Which is why the technological leap in 1953 changed literally everything.
Oh, absolutely.
Inch Edler and Carl Helmuth Hertz, working over in Sweden, they took industrial ultrasound equipment like the heavy machinery used to find microfractures in metal in shipyards.
Yeah.
And they pointed it at a beating human chest.
The birth of echocardiography. By bouncing those high-frequency sound waves off the moving tissue, they could actually map the structures inside.
You didn't have to guess anymore based on a collapsing pulse or a subtle whoosh in a wooden tube. You could literally watch the valve leaflets opening and closing in real time on a screen.
Right.
And that ability to see the valves completely shattered the medical world's understanding of who was getting sick and why. Because for most of the 20th century, if a doctor said someone had valve disease, they were basically talking about one very specific thing, right?
Rheumatic fever.
Rheumatic fever.
In 1904, the German pathologist Ludwig Aschoff definitively linked the scarring found on adult heart valves to childhood bouts of untreated strep throat.
Untreated strep throat? That's crazy.
It's a tragic case of friendly fire, really. The body's immune system builds antibodies to fight the strep bacteria. But because the proteins on the surface of the strep bacteria closely resemble the proteins on the tissue of the heart valves, the immune system gets confused.
Oh, wow.
Yeah, in a delayed cross-reaction, it ends up attacking, inflaming, and permanently scarring its own heart valves.
Yeah. So for decades, the entire clinical focus was pretty straightforward. Prevent strep throat, you prevent rheumatic fever, you prevent valve disease.
Exactly.
But then echocardiography reveals this massive iceberg of patients that stethoscopes were just missing entirely. In wealthy nations, antibiotics and better living conditions were largely wiping out rheumatic fever, so the old enemy was fading. But then the 2003 Euro Heart Survey, which was this massive study of over 5,000 patients, it quantified a total paradigm shift.
The new leading cause of valve disease wasn't an infection at all.
Right. It was degenerative calcification.
Wear and tear is driven by the exact same risk factors as clogged arteries. Advanced age, hypertension, high cholesterol. The repetitive mechanical stress of a valve opening and closing 100,000 times a day for decades, it causes microscopic tears.
Just from swinging on the hinges.
Yep. And then calcium deposits build up in those tears to patch them. Yeah. Eventually, that turns a supple, paper-thin leaflet into a rigid, stone-like mass. So the disease didn't disappear. The fundamental mechanism shifted.
Right. But I do have to push back a little here on the idea that the old enemy is fading. Because reading the epidemiology, it seems dangerously inaccurate to call rheumatic heart disease a solved historical problem, like polio or scurvy.
You are entirely right to push back on that. Rheumatic heart disease has nearly vanished from wealthy countries, but globally.
Right.
It remains a devastating burden.
Right.
It is fundamentally a disease of poverty, overcrowded living conditions, and global health inequity. It is currently killing young people in their 20s and 30s across sub-Saharan Africa, South Asia, and the Pacific.
Simply because they do not have access to basic, cheap penicillin for a childhood sore throat.
Exactly.
We are talking about tens of millions of people worldwide living with a completely preventable disease, while the industrialized world has kind of moved on to treating the wear and tear of old age. The textbook throws them all in the same chapter, but the realities are just worlds apart.
They truly are.
And beyond rheumatic scarring and aging, the anatomy throws a few other curveballs, too. Like, there are two specific subtypes that show just how varied this plumbing problem can be. Barlow's disease and the bicuspid valve.
Oh, yeah. So Barlow's disease, commonly known as mitral valve prolapse, was described in the 1960s. And it causes a distinct click murmur sound.
A click murmur.
Yeah. The tissue of the mitral valve is abnormally stretchy. So when the powerful left ventricle squeezes, instead of the valve doors snapping shut and holding firm, they billow backward into the upper chamber.
Like a parachute catching too much wind.
Exactly like a parachute.
And roughly 2 to 3% of the entire population has this. It's strikingly common. Most people never have symptoms, obviously. But for a subset, those parachute strings eventually snap, progressing to severe mitral regurgitation.
And then there's the bicuspid aortic valve, which is the most common congenital heart defect. 1 to 2% of people are born with an aortic valve that only has 2 flaps instead of the normal 3.
Okay, so what happens when you only have 2?
Well, a normal three-leaflet valve distributes the mechanical stress of blood flow very evenly. When you only have two hinges, the physical stress is highly concentrated. It's totally quiet for decades. But that localized stress predisposes those patients to develop severe wear and tear calcification 20 or 30 years earlier than someone with normal anatomy.
Wow. So, okay, you have a mechanical failure. You've diagnosed it with ultrasound. You know if it's from aging, infection, or a congenital quirk. How do you actually fix the plumbing? Because here's where it gets really interesting. Fixing the plumbing sparked some of the most intense and honestly brutal debates in modern medicine. The birth of valve surgery was just a terrifyingly steep, very bloody learning curve.
It was. I mean, the mechanical idea was perfectly intuitive. The leaflets are fused and calcified. Let's just cut them apart.
Right.
But executing that safely on a beating heart was lethally difficult.
There was a 25-year gap in surgical success. In 1923, a surgeon named Elliot Cutler in Boston tried to open a stenotic mitral valve using blunt instruments.
Oh, yeah.
And it was a complete disaster. You can't just blindly cut a rock-hard, calcified valve leaflet without it tearing unpredictably. He basically turned a stiff valve into a totally shredded, leaky valve.
Yeah.
He turned stenosis into lethal regurgitation.
And the operation was largely abandoned for an entire generation after that.
It took until 1948 for Charles Bailey and Dwight Harkin to perfect the closed mitral commissurotomy.
Yeah, and the visual of this procedure is just wild.
Yeah, it really is. They weren't stopping the heart or using a bypass machine. I mean, those didn't even exist yet. They were blindly sticking a finger with a small blade, literally strapped to it, into a beating human heart.
Just feeling around in the dark.
Right, feeling around in the dark, locating the fused leaflets, and manually splitting them apart with sheer physical force. It takes immense nerve.
But that innovation was desperately needed because the stakes of doing nothing are incredibly high.
Yeah.
A landmark 1968 study by Ross and Braunwald established a chilling reality for aortic stenosis. We call it the 50% at 2 years rule.
Okay, explain that.
So a patient can have a narrowing aortic valve for a decade and feel completely fine. They're totally asymptomatic. But the moment that severe stenosis becomes symptomatic, the moment they experience chest pain, fainting spells, or heart failure, a clock starts ticking.
Wow.
When symptoms appear, average survival without a valve replacement drops to just 2 to 3 years. Mortality clusters sharply right after symptom onset. That is a terrifying cliff to fall off.
Man. And because that survival cliff is so sudden, it forces doctors into some incredibly high-stakes decisions on when and how to intervene.
Exactly. Which brings us to 3 live debates currently shaping cardiology. Debate number 1 is timing.
Timing. Okay, so the traditional camp advocates for watchful waiting. Basically, open heart surgery is inherently dangerous, so wait until symptoms actually appear before you crack someone's chest open.
Right. But the early intervention camp argues that waiting for symptoms means waiting for irreversible cardiac damage.
Yeah.
If you recall the cardiac remodeling we discussed, the inward thickening and stiffening of the heart muscle.
The bodybuilder heart.
Exactly. If you wait too long, you might successfully fix the valve, but the heart muscle is permanently scarred. It will never relax normally again.
Which leads into debate number 2, repair versus replace. In the 1970s, the French surgeon Alain Carpentier pioneered the French correction. He proved that for the mitral valve, painstakingly reconstructing and repairing your own native valve is vastly superior for long-term survival than just ripping it out and putting in an artificial one. Because mechanical valves require lifelong blood thinners and, bioprosthetic pig or cow valves wear out and need replacing.
And Carpentier's philosophy is widely accepted for degenerative disease. However, it remains fiercely contested for other subtypes, particularly secondary regurgitation.
What's that?
That is when the regurgitation is caused by a dilated, failing heart muscle pulling the valve apart, rather than the valve tissue itself being broken. It's a much harder problem to solve.
Oh, I see. Well, that brings us to debate number 3, which honestly sounds like absolute science fiction compared to blindly cutting valves with a finger in 1948. TAVR, transcatheter aortic valve replacement.
Yes.
April 16th, 2002. Rouen, France. A cardiologist named Alain Cribier.
He had a 57-year-old patient who was actively dying, just in severe shock. And he was turned down by literally every surgeon for open heart surgery because the risk of death on the table was near absolute.
So Cribier does something radical. He takes a replacement valve, squishes it down into a tiny metal catheter, and snakes it through a vein in the patient's leg.
Yep.
He threads this wire all the way up into the beating heart, positions it right inside the old, rock-hard calcified valve and inflates a balloon. The balloon violently crushes the old valve out of the way and expands the new valve into place.
All while the heart is beating.
No cracking the chest, no heart-lung bypass machine.
It began as a last resort Hail Mary for the inoperable. But by 2019, the partner trials proved that TAVR actually performs comparably to open surgery, even in low-risk patients.
That's huge.
It has fundamentally reshaped the surgical landscape. What used to require a massive open chest trauma and a long ICU recovery is moving closer to an outpatient procedure.
It's incredible. So what does this all mean for us? We started with the idea that stenosis is a pressure problem squeezing the hose, causing the heart to thicken. And regurgitation is a volume problem, broken sump pump, causing the heart to stretch. We saw how the disease completely shape-shifted over a century. From a rheumatic infection of the young to a degenerative wear and tear disease of the aging. And we saw how the technology we use to look at the problem, from a rolled up piece of paper to shipyard ultrasound to transcatheter delivery, literally drives our understanding of the disease itself.
And this matters profoundly to everyone listening because calcific aortic stenosis is a disease of longevity. It was the plumbing bill that comes due for a long life.
Yeah.
If you are lucky enough to reach your 70s or 80s, it's highly likely that you, a parent or someone you love, will have to navigate this wear and tear reality.
And we learned that replacing a valve doesn't instantly heal a scarred, remodeled heart muscle. So with procedures like TAVR making the solution less and less invasive, what happens to that traditional idea of watchful waiting?
Well, it points to a fascinating, somewhat provocative future, doesn't it?
How so?
Well, if transcatheter valve replacements eventually become as safe, durable, and routine as getting a dental crown, might cardiology completely abandon watchful waiting?
Oh, wow.
In the future, we might preemptively swap out our aging heart valves in our 50s, long before they fail, purely to prevent the heart muscle from ever having to strain and remodel in the first place.
Just swapping out the plumbing before the pipes ever have a chance to burst.
Exactly.
That is definitely something to think about the next time you feel your own pulse. Thank you for joining us on this deep dive. Keep questioning the world around you, and we'll see you next time.